So let's move on to the second part of the discussion today, which is, again, to dig a bit deeper into our treatment of a newly diagnosed patient. What are in the NCCN guidelines for the treatment of newly diagnosed multiple myeloma, Andres?
I mean, the guidelines are generated based on mostly category 1 evidence, which is data coming from randomized phase 3 trials. Fortunately, our members of NCCN are very much open to accepting emerging therapies, so they incorporate usually in category 2A with good evidence from single-arm trials, recommendation for selection of some of the regimens which we discussed earlier today. In fact, neither RVD or KRD have met this level of evidence that they would be one evidence, but that's eventually guidance to some extent.
Is that right? Isn't VRD not level 1 now based on the
It is already level 1, but it is not yet, to my knowledge, approved by FDA as a regimen. So that's sort of a little bit of level of evidence.
You were telling me earlier that you find that reimbursement, if it's on the NCCN guidelines list, you're usually covered.
Correct. If there is a more controversial choice at any point of the treatment, and we are asked to discuss with the payer whether this regimen is really acceptable at this time or experimental, and we have a lot of push back and with statements that they are too experimental, then usually argument of, oh, this regimen is not on NCCN guidelines, not approved yet, not published yet. So these are the layers of filtration from payers and to getting the selection.
Raphael, talk a little bit, we talked a little bit earlier about the drugs that are being used, but what is your frontline regimen of choice? Is it a doublet, a triplet, elderly, frail? Why in both cases?
Sure. So with the exception of the very elderly or frail patient, I always use a triplet. And I think my choice is now dictated by the recent clinical trial. So for non-transplant eligible patients, the majority of them are going to get a combination of daratumumab, lenalidomide, and dexamethasone, which I'm already doing in my practice. I do scratch my head a little bit with a high-risk patient that's an elderly.
You're saying you're already doing it now. We're expecting approval any day now, but you've been able to get it already?
I have. So far, we haven't had problems with that aspect of it. So the question, though, is what to do for the high-risk patients. The confidence intervals are right there, so it doesn't appear to be any different. But the Alcyon trial didn't show, which tested the use of bortezomib frontline benefit as well. So I still don't think we know perfectly how to treat high risk in the elderly. Fortunately, it's a small minority of patients. It's about 10% of patients in the elderly. In the transplant eligible patients, my current standard now is a combination of carfilzomib, lenalidomide, and dexamethasone, usually for about 4 cycles, and then move on to stem cell transplant.
Mary, patient perspective, we covered a little bit on earlier, but do you see preference for triplet or doublet therapy or one drug class over another? Are people worried about toxicity, or is that not important to them initially?
Certainly, patients are worried about toxicity, and they, again, some patients really want to hit the disease as hard as possible, and they're not as worried about toxicity, whereas others are really more interested in maintaining some quality of life, so they may accept something that maybe has less toxicity for them.
What about transplant? How do patients react to transplant? Are they still nervous, or are they mostly accepting now?
Well, I mean, I think that there's this sort of new generation of patients who are actually beginning to question upfront transplant, right? And there is a lot of data emerging that there's some of these newer therapies that we have available are so effective that patients are in some cases electing to delay their transplant. They're collecting cells, but they're just delaying the transplant.
You think that's a good thing?
I think that the jury is still out on that.
The SWOG trial was a large phase 3 trial comparing, not the SWOG trial, it was the French that did it, I guess, was, forget what they call it. But
IFM 2009.
Okay, thank you. This was VRD versus RD, and it did show pretty substantial benefit. It was VRD transplant versus VRD alone. It did show substantial ongoing benefit to transplant. Has that impacted your practice at all, Raphael?
Not really. I still think that for most patients, transplant is still a good option. There's a subset of patients who have very deep responses, who may have personal circumstances or preference that would opt out of transplant, which I actually respect and support if they want to do that. But everything else being equal, I think most patients need to go to transplant. I think we'll talk more about the Forte study too as well that is being presented.
Well,
but
thank you for that intro, because I was going to go right there actually. So the Forte trial which is a very interesting trial, has been presented at this meeting. This is a trial of the KRD, your favorite regimen, carfilzomib, lenalidomide, dexamethasone, continuously versus the same regimen interrupted to do a transplant. And tell us what that's showing so far, Andre.
We will see a presentation, but from abstract and previous presentation updates from the study, there are two main observations. First, that KRD is superior statistically compared to KCD. C stands for cyclophosphamide.
There is a third arm in the trial.
And all of both groups of patients receive exactly the same treatment 4 cycles before, 4 after transplant, and transplant in the middle. There was a third arm, KRD, for 12 cycles with patients collecting stem cells but not receiving transplant. And to some extent, surprisingly, the difference in depth of response and also in the level of the deepest responses was very comparable between 2 arms, indicating that possibly you don't need transplant if you extend KRD. This was the 12, so a bit longer, 4 cycles more. But from abstract, and we need to see the details, it appears that the group of patients who have potentially increased risk, there is a prolonged duration of remission if you incorporate transplant into the treatment strategy, which is in line with what we have previously seen with KRD, transplant KRD, followed by KRD without.
I think we were all quite excited at the ASH meeting that this was the beginning of the end of transplant if you could give KRD for 12 months without a transplant, but it looks like that's beginning to slip now, and transplant still. Is that your interpretation of the abstract?
Well, you know, if true, as we both know that statement, if true, and not of what's reported, just because the numbers are small, so it needs to be validated, the data would suggest that the early relapse is prevented by transplant. So the question is a CR the same as a CR? In other words, is the CR of transplant different from the CR that we get from other treatments? Now, historically, we know that patients can go into a CR that's very long-lasting without anything else after transplant, which is less common with the medication. So I think that's why this study needs to mature as fast as possible. Of course, everyone's going to see whatever they want to see. So transplanters will say, see, they're relapsing. Non-transplanters will point out that, in fact, we may be getting closer to eliminating transplant from myeloma treatment.
Do you think with daratumumab we'll get there? I mean, we never really said earlier. I mean, why? Maybe let me take a step back. Why KRD, not VRD? There's no evidence it's any better, Andre. Why are you using KRD?
There's no absolute evidence from randomized trials. 2 studies are in progress. One very advanced ECOG.
KRD?
Well, indirect data from studies reported to date, and not only one, but for KRD 3 or 4 studies, indicates that the respective landmarks of activity of a regimen are superior for KRD versus VRD, both response rate, depth of response, and duration of response. You can.
They're using. Well, we'll maybe come back to dosing schedule later. You've switched to KRD recently too,
Sure.
I think.
The reason I switched is a story. We have many grateful patients that come to the clinic, say, "Doc, thank you for everything you've done for me. By the way, I still don't feel my feet." And that is still with a weekly subcutaneous administration of bortezomib. And it's trade-off. So it's the peripheral neuropathy versus the risk of increased cardiac toxicity. From what we understand, it's a little bit less common in frontline, and it's
what is less common?
Cardiac toxicity associated with carfilzomib. And from what we can tell, also a large part of it is reversible. Now, we do have a phase 3 clinical trial that is going to be reported in the near future, E1A11, that will compare KRD versus VRD. But I think given that patients are going to live for years, I really don't want to see that long-term peripheral neuropathy as part of their baggage.
It's fair to say, though, that VRD remains a sort of backbone in much of the country, right, outside of
That's
academic
a perfect
centers.
choice, of course.